So we are focused on optimizing the diagnostic pathway. So the prostate cancer best practice timed pathway was published in 2018, and it was developed by the teams at UCLH, at the Christie and the Marsden, brought together by NHS England and supported by Prostate Cancer UK. And it used the evidence from the PROMISE trial to create a prostate cancer diagnostic pathway that could deliver the new time to diagnosis standard within 28 days. And the idea of these timelines is about ensuring that people who are referred have as short a time as possible to learn about their diagnosis, but also crucially that it reduces anxiety. And we know that one of the most stressful times for patients is that period between being referred with suspicion of cancer and actually finding out whether you have cancer or not, and what your diagnosis is. So it's really important to try and keep that time as short as we possibly can, including telling all those people that they don't have cancer. But the key thing about the PROMISE trial was the introduction of MRI. So PROMISE showed us that using pre-biopsy multiparametric MRI, it enables us to triage men and reduce the number of men who require a biopsy by at least 25%. That it can diagnose over 90% of significant cancers and crucially diagnose fewer insignificant cancers. But we also know that since 2018, there's been a lot going on within the prostate cancer pathway. You know, we've all lived through a pandemic and then the recovery from that pandemic. We know, because we work with NHS clinicians all the time, that there are huge pressures on the prostate cancer pathway. And so today is about taking a pragmatic look at how do you cope with your volume of referrals? How do you deliver best practice in a really strained system? And I'm really pleased to say that we are joined by some experts in this space who have really valuable experience at delivering improvements in the diagnostic pathway. And first up, I'm going to be joined by Dr. Netty Kinsella. And Netty is a Uro-Oncology Nurse Consultant at the Royal Marsden. And I'm going to pass over to you, Netty. You're going to talk us through the SPEED pathway as used in the Marsden.
I am indeed. Thanks ever so much, Amy. So I want to talk about how we took best practice pathway into the rapid diagnostic pathway, which I'm sure a lot of you are familiar with, through to our SPEED pathway, which I will talk about shortly. But just a little background. So next slide. So we know, and Amy's alluded to the problem that we've had with prostate cancer diagnostics, that it's been a very fractured pathway of multiple visits for the patients. And it's led to a lot of overdiagnosis, overtreatment in the past, because we've perhaps over-investigated patients. But we had a problem with how we brought large numbers of patients through that pathway. Next slide. So we piloted the RAPID project back between September 17 and March 2018, so way before we had the problems of COVID. We launched them in 3 different centres across southwest London, a couple of hospitals that were cancer centres and one that was a district general hospital. And that was really to look at whether or not there were any differences between those sites, and also to see whether or not there were differences in the way that we'd need to deliver this pathway in the future, based on the constraints around facilities. Next slide. So the RAPID model was is a straight test model. It's a possible telephone assessment of a patient, or it could be no assessment of the patient, and just a determination of their suitability and the necessity for an MRI based on potentially just a PSA test and a few bits of information delivered by the GP on past medical history, allergies, etc. The idea was that we cut out the initial first appointment straight to the MRI by someone clinically triaging them, and then those people that needed a biopsy, if it's suggested so on the MRI scan, were then put straight in to have a prostate biopsy, and in this case a targeted fusion biopsy. We decided that we'd move all of those biopsies to a transperineal approach, so there was a collective move towards that technique to reduce infection risk, and also to a local anaesthetic rather than a general anaesthetic biopsy. And that was obviously all to reduce the time to a diagnosis, to get in line with a faster discharge when there was no cancer, reduce the hospital visits, and then get faster access to treatment. So it all sounded really good in practice. Next slide. Next slide, thanks. So we did a lot of work around establishing buy-in on those 3 sites with a variety of people. So medics, nurses, radiographers, management teams, admin staff, and operating room staff. We ran virtual weekly meetings and monthly face-to-face meetings until all were on site. Next slide. We came up with, in the end, a plan to move to our rapid pathway over a series of steps in most cases. So our conventional pathway, we moved to a best practice pathway, and from there on to the rapid pathway. So in most of those centres, it took 3 to 6 months to get us to the point of the rapid pathway. Next slide. We did a series of work downs in these centres to ensure that we had the capacity to be able to deliver very quick MRI slots, and also in some cases same-day biopsy. We were able to demonstrate that across all of those 3 pilot sites during this pilot phase that clinical triage meant that we could ensure only patients suitable for MRI were getting them, or getting these ring-fence slots, that patients that had urinary tract infections were sent back to primary care rather than going through a pathway, and that actually many of the patients were discharged very early in the pathway with a negative MRI, so went with no biopsy. And the next slide, I think, shows how prior to the pilot, we weren't hitting our targets. After the pilot, we were very much closer to the targets that have been set for us, which was great. Next slide. So why am I sat here talking to you about our speed pathway? Well, there were problems, and next slide, I think, demonstrates some of those problems. So we got to the end of the first year and we started to look at how many of those patients coming through the service were actually ending up in an MRI scanner. So around 90% of the patients that were referred in were being booked for an MRI. And it was becoming quite unrealistic to expect that the reporting times for those MRIs were going to be done in a timely fashion. We were very popular. Those 3 sites were very popular to send their patients to. So instead of actually having a very static number of patients coming through the front door, patients were coming from all over the country, in fact, all over London, to access these very quick diagnostic pathways. We found that our biopsy practitioners weren't particularly happy because they have very limited clinical information about the patients. They come straight from a triage. You had the information from the GP. They'd had an MRI scan, needed a biopsy, and we didn't really know a lot more about them. Didn't know about their waterworks, didn't know about any other symptoms that they might be experiencing. The urology team just started to express being little bit unhappy about triaging a patient just based on referral information from the GP, so without speaking to the patient. They felt that the benign conditions weren't being assessed, and certainly they weren't being treated. And we were creating this second waiting list of patients on the kind of benign side. The patients felt that it was unsatisfactory because they weren't actually seeing anyone up front, didn't really understand what the MRI was, didn't really understand why they were being discharged. The original presentation at the GP might have been for urinary symptoms, but they weren't really getting a solution to the problems that they were presenting with. GPs, when asked, weren't happy. These symptoms weren't being addressed. Patients were being referred back to them, and then they were going through the process of re-referring back, in many cases to the same hospital for benign prostate enlargement. Next slide. So we started to think about how we might change this. And we used a process called experience-based co-design. It's a very flexible approach to developing services, and helps to meet the kind of strategic objectives of quality of care, brings patients and staff together, gives lots of inspiration to staff hearing from patients, and they're motivated to kind of make changes or sustain changes at the end of the day. The focus is really on realistic goals and solutions, so something that's done together within the constraints of the kind of pathways and the capacity of the hospital. The lovely thing about it is it doesn't require any kind of ethical approval, just service improvement approval or audit approval from your local committees. So what did it involve? Next slide. So we had to capture and understand what the problems were really. So we identified patients and staff that actually had been involved in the rapid pathway, and we did some interviewing with them, as well as running a survey with a larger volume of people. And what that did was actually give us a snapshot of the problems that there were in the pathway, but on a much wider scale. Next slide. So we found these were the highlights that were found to be a consistent theme within those interviews, and also within the surveys that we sent out. So the straight to test model, that decision depends on the quality of the referral information in the first place. People found that or felt that the focus was just on cancer. Other symptoms were ignored. Patient with waterworks problems were discharged or had to be re-referred to join this second waiting list. Again, urinary symptoms not assessed. There was limited MRI reporting capacity, and certainly limited MRI capacity, full stop. There was no method for actually managing patient anxiety, because the clinical nurse specialist team were actually not involved in the diagnostic part of the pathway. And there wasn't a clear accountability or responsibility from anyone for patients on the straight to test pathway, not until they got to the point of biopsy. So that contact and support through diagnosis was a real theme. Next slide. So we started to look at how we might deliver something that looked better. And in red here, you can see the kind of solutions that we came up with that has led us to this speed pathway. So thought about seeing all of the patients in a dedicated clinic. So previously they had been ring-fenced slots in all of our consultant clinics. Patients were seen all over the place. It was very difficult to keep control of the pathway after the point of MRI. And actually a dedicated clinic made that process a lot easier. We felt that all patients actually should have upfront uroflowometry done in a diagnostic setting. That also helped us determine those people that might go into urinary retention if we ended up biopsying them. But also that there was a direct referral system to benign services. We're possibly a unicorn amongst hospitals in that we don't have a benign service, so that meant making friends with our local hospitals to ensure that we had a very efficient pathway through to our benign or functional urology colleagues. We explored hot reporting and AI options. That's something actually that only now we're just about to implement. But we also created, as part of the support around patients through that diagnostic period, the idea of a diagnostic nurse specialist rather than a clinical nurse specialist, and to delineate between the two, because the amount of input that patients might need right at the very beginning of that diagnostic pathway through to the point of treatment is actually underserved by nurse specialists who are busy with the patients on treatment, and we found it was a time where we could make most impact. And the last change we made was actually to make this a nurse-led diagnostic team with full accountability. Next slide. So this is what our pathway looks like. It's a very busy slide. Very happy to share my slides with anyone afterwards. But we have very separate jobs for each individual as part of this pathway. So we have a team of nurses and coordinator support workers that run this pathway. So from the screening of the referral, which is done by our AMP workforce, through to the coordination and the tracking of these patients, which is done by our coordinators, everyone has a very specific role within this clinical model. But it's all aimed at actually getting people through this in a very short space of time, with the focus on an upfront face-to-face clinical appointment to do an assessment in person and to start to build that relationship with the patient. Next slide. So we measured our pilot of the pathway, which we did just before COVID, and we compared it to our rapid pathway. Obviously, small numbers in comparison. We reviewed how many patients in our face-to-face model went through to an MRI, and we were certainly doing well in limiting those or limiting the necessity for people to go through imaging as well. We talk all the time about prostate biopsy being very invasive, but actually the number of patients that find MRI challenging to get through is quite high also. So actually reducing the number of MRI scans that we were asking our clinical teams to do meant that they had more capacity to hot report those MRIs. We had a consistent percentage of our patients undergoing MRI that were going through biopsies, which was reassuring, and also the numbers of patients diagnosed with cancer. And our mean referral time from our getting our referral from the GP to actually the MRI scanner was around about 5 days, with the aim to actually reduce that down to 3. Next slide. I believe that the service actually works really well, and we've continued to measure it actually throughout the entire time that we've been running it. So we've got something like 1,400 responses to surveys now that have been completed since 2019. And we are in a constant state of updating our pathway and making changes as part of that in response to the surveys that are being sent out. And I think that's really important, to have a very dynamic reaction to a service that you're actually delivering. So having time to do that as a clinical team and as a management team is really key. But what it has done is allowed us to reduce the number of face-to-face contacts. Other than their first appointments, we actually do most of our calls to patients, our virtual interactions with patients virtually or by telephone, rather than bringing them into a hospital, therefore leaving more capacity for us to be able to see new patients. So if wanted, no patient waits more than 3 days for an appointment from the time that we receive their GP appointment. Thank you very much.
Thank you so much, Netty. Fascinating presentation. There's one question come straight into the chat, but please feel free to drop further questions in for Netty. And I've got a couple of questions that struck me as I was listening to you. But if I come first to Joseph's question, you talk about it being a nurse-led diagnostic pathway and having these diagnostic nurse specialist roles. Have you found any challenges recruiting or retaining these roles?
Not yet, but I think as so we are basically spending a lot of time training our own in-house nurses, and I think we've had quite a nice pathway from people progressing from our diagnostic nurse specialist roles into our ANP roles, which is nice. We run weekly training sessions with our nurses, so we have a kind of virtual education session every week where either one of our team will present on an aspect of cancer or benign disease, so that everyone is upskilling constantly. I think as these things become more popular, and I hope they do, because I think nurses do a very good job at delivering this kind of service. But as they become more popular, I'm sure that we'll be in competition with other hospitals for these nurses. But I also hope that we're able to invest in these kinds of roles in the future, and that the value is seen by our medical colleagues. I know that I've certainly been able to change the hearts and minds of our consultants at the Marsden and a few others that have come into contact with the service. So I think it's coming. We're coming.
Yeah. I had a hearts and minds question, actually, because the rapid pathway is held up as being the national exemplar. I was in a meeting just last week where people were kind of singing its praises and aspiring to get there. And I find it fascinating that as one of the original people who was working on that pathway, you have now moved on from that. And I guess my question was, how much resistance did you face to that? And how did you overcome that resistance?
Yeah, so I mean, the overcoming the resistance was possibly the easier part, because in setting up Rapid in the first place, actually all of the key stakeholders all knew each other, and there wasn't a lot of change actually between when we set up in terms of personnel and post-COVID. Pretty much most people stuck where they were for quite some time. So I think it was timely, and we were able to kind of communicate effectively because we had that network of stakeholders set up. I don't think it was difficult because we had the evidence there. So I think it's really important to evaluate your service constantly. And I think our survey that we were constantly sending out to patients spoke volumes. So it was very easy to present the data that people weren't happy with it. It didn't take many, the collection of emails from GPs who weren't happy with it as well was not difficult to sift through. And, just looking at the number of radiology referrals for MRIs on patients that probably should never have had an MRI, that also wasn't difficult. I mean, we keep a massive Excel spreadsheet of our patients that means that we can go back and review patients in particular cohorts. And I think, again, that's been very valuable in terms of giving the evidence for why we should change.
Yeah. I'm just going to ask one final question here. So from John, how quick are MRIs reported to ensure same-day biopsy? This is one of the issues they're facing, the hot reporting of MRI.
Yeah, so I've got to say, we rarely do a same-day biopsy. we do a same-day appointment and MRI. So we've got all of the diagnostic work done up to the point of MRI done. Our MRIs are either reported same day or within a couple of days. We have 2 biggish clinics a week.
Oh, I think we've just lost Netty. Hopefully she can rejoin us. But just to pick up her point, I think it is a really interesting and important one, that I think there is a lot of fixation on same day MRI and biopsy, but it doesn't have to be done that way. And so maybe this is a good moment to pass across to our next presenters who are joining us from Leeds. So I'd like to welcome Rachel Baker-Green, who's a prostate cancer advanced clinical practitioner, and Arbaaz Allybux, who's a project manager, who have been working on the Leeds pre-clinic triage process and 7-day access. So over to you both.
Thank you, Amy. So I'm going to talk through what we've been doing with our prostate cancer service here in Leeds and how we've been improving our diagnostic pathway. Next slide. So the Leeds Teaching Hospital NHS Trust is one of the largest teaching hospitals in Europe. It's also a specialist centre for cancer, but also is a local hospital for the residents of Leeds. Last year we dealt with 47,000 two-week wait cancer referrals. Specifically in the prostate service, we see on average around 135 referrals per month on the two-week wait pathway. So as we know, there is a north-south divide in men being diagnosed with prostate cancer when it's too late to cure. In Yorkshire, we're obviously aware of this. Our rates are 20%. In comparison to London, where the rates are 12.5. For us, that means 1 in 5 men that present have got metastatic disease. In Leeds, our national prostate cancer audit data from last year, 2023, showed that our percentage rates, specifically in Leeds, stand at around 23%. Next slide, please. So the reasons for this are multifactorial. In Leeds, 26% of our population are classified as living within the top 10 most deprived areas nationally. Within our prostate cancer service, you can see our local data there. That means that approximately 33% of our patients come from IMD deprivation groups 1 to 3. Next slide. Our Leeds ethnicity data also shows within the last 10 years we've had a slow decline in the white population and an increase in our BAME groups. We are looking at this with consideration for our future planning of services. Our local data and demographics we use to plan our services going forward. Next slide. So our original prostate cancer pathway, which is from approximately 2 years ago, very much like Netty was describing, our GP sent in a referral. All patients were seen by our consultant. This first step in a face-to-face clinic took approximately 30 days. Depending on which consultant they saw in our clinic, the next step was consultant dependent. So for example, if they needed an MRI scan, it would be booked on the day, but they may their follow-up time may vary from 2 weeks to 6 weeks. And that would also be when their biopsy was requested if that was needed. There was also very inconsistent patient information given and overall a poor patient experience.
So we started looking at this project in the start of January 2023, and we needed a framework really to base the project on. And the Leeds Improvement Method gave us a strong foundation when we started looking at the project. So initially we looked at the lean methodology. We looked at the 8 ways that may happen in a pathway, and we concentrated on the 2 main issues that we found, which was the over processing side, where we acknowledged that the administrative processes between each interventions felt very heavy, very clunky, and we wanted to fix that. But equally, most importantly, we recognized that patients were waiting a long amount of time to be assessed in a clinic and to have their MRI. So in December 22, for example, we saw it took patients on an average up to 24 days to have an MRI. So we put together a steering group of core MDT members with our lead clinician, our consultant MDT lead, Mr. Bill Cross, and various members from radiology, our CNS team, ACPs, and really drummed up that stakeholder engagement with the right sort of clinical leadership for us to be able to make some changes. And we planned a multitude of different things that we could look at, and entered multiple PDSA cycle, and ultimately looking at the data from last month, and Rachel's going to go through in terms of the detail of what we've done. But ultimately, it's meant that in June 24, on average, patients were waiting up to 6 days to have an MRI done, a reassessment, the first assessment clinic being at day 4. I'll hand back over to you, Rachel.
Thank you. So this is our new diagnostic pathway. Just flash that up, thank you. We've introduced an ACP-led triage service, but it's not just a triage service. We do actually telephone every patient, and they do get a telephone assessment. This part of the pathway helps us to determine whether a patient needs an MRI scan, whether they need to come to a face-to-face clinic, or whether they're discharged. If they do need an MRI scan, that's booked with them on the telephone. We book straight onto a booking system with radiology. It's a joint system. They're given a date and time on the phone to ensure they can attend, but also they can be given directions and reassured as well. And then we aim to do the MRI scan within 5 days, but actually we can usually offer the same day or next day MRI scan. Once the MRI scan has been done and reported, the patient would be sent a text message, and we will telephone them within 5 days with the outcome of that. We have also digitalised all our information, which includes leaflets, patient assessments, things such as SHIM and IPSS scores now are all digitalised, which patients can be assessed over the phone much more easily. We're looking at AI interpretation of MRI scans for our positive MRI scans, which will negate the need for a phone call. Next slide.
So one of the things that we wanted to acknowledge was how our waiting list was managed, and how this has been changed throughout this project. So historically, we had these 2 massive waiting lists. One of those containing our first 2-week wait referrals, any PSA reviews, or any referrals coming from other sources, and a second waiting list that had patients waiting for MRI, typically a biopsy, patients waiting for an MDT discussion, and even some benign patients in there. And as a cancer navigator or cancer pathway manager, it's very hard to determine without validating the list where the patient's currently sitting. And we acknowledge that that was one of our biggest challenges in this pathway. So we were able to split those waiting lists into very clear ones, whereby the patient would then move through that pathway from a referral holding waiting list all the way to the diagnostic waiting list, through the MRI and the biopsy waiting lists. What that means is that we've done this without creating additional workload. So rather than it being a validating process to understand where the patient's sitting and to understand whether we need to make any adjustments, it's more proactive. The patients are sat where they should be sat on our system. Alongside this, the administrative teams and operational team have done a fantastic sort of work in terms of setting clear targets for for administrative staff and for our cancer pathway managers. So we can see very clearly if a patient, for example, is going beyond that set target that we're given, we're empowered to escalate to our operational managers who can go and make some changes to rotas or to sessions to ensure the patient is seen on time. And it's helped us develop some very clear collaboration with our radiology colleagues in terms of how those waiting lists are set up. One of the other things we wanted to talk about as well is how we started to capture health data as well on our referrals coming through. So I'm just going to flick my screen to the dashboard. So as part of this project, we worked really closely with our Leeds Cancer Centre colleagues, and we pulled together this dashboard that contains multiple sort of demographics from sort of IMD score to ethnicity to age. And what we wanted to do is just assess whether the changes we were making was it deepening health inequalities for the region. And one of the so for example, at the moment we're looking at the baseline data, so that's before the project went live, and we can sort of split the data down to IMD, the three main sort of most areas of high deprivation, IMD 1 to 3, and we can get some data just to sort of say, just to see sort of 40, for example, here 45% of those patients referred before the project was seen within 7 days. We went live with some changes in Q1, and we were able then to assess what impact that's had. So then we sort of saw that within those IMD areas, actually 65% of the patients were then seen within 7 days. So that's give us some sort of assurance that we were not deepening health inequalities in the region with regards to the prostate cancer pathway. If I go back to the baseline and take away the IMD scores, and just we can also look at ethnicity as well. So looking at the number of Black patients, again, smaller numbers with 16 in our baseline figure, and we know 37.5% of those were being seen within 7 days. And when we made the change, we saw that jump up. And again, we're not saying that this change narrowed health inequalities, but it's more around us being assured that the changes we are making is not causing an additional unwanted risk. So yeah, that's the slide, the data there in terms of 38% of baseline Black men being seen within 7 days, going up to 80% post implementation.
So in summary, the benefits of introducing an advanced clinical practitioner-led and delivered diagnostic service is we've reduced our diagnostic time. We also have the day-to-day clinical oversight over the pathway. We know how many referrals are coming in, and we do quite often adapt our working week to respond to surges and demands for different elements of the pathway. It's a sustainable team, and that ensures we can provide continuity of care. Overall, we feel we've improved patient experience. We're still ongoing with our service developments. Our next step includes an advice and guidance service to GPs to try and reduce some re-referral rates. We are looking at a bespoke advanced prostate cancer service for advanced prostate cancer men. And at the moment, we're also looking at our access and processes with regard to biopsies on the next part of the pathway. And this will be guided by our health inequalities data that we continue to gather. Any questions?
Thank you so much to both of you. And can I just start by saying I am blown away by your health equity dashboard. I've never seen something like that done in the NHS before, and it's so impressive. It's a topic that we are very interested in tracking the impact of service changes on health equity, and it's fantastic to see you embedding that within how you're planning service development. So huge appreciation that you have done that, and really great to see that it appears to be having a positive impact. I know sometimes the concern is that when you accelerate pathways, that can have a negative impact. So it's fantastic stuff. Please, everyone, feel free to drop questions into the chat. I would just like to kick off with a reflection really about, well, what did you learn about making service change through delivering this intervention, this change in how prostate cancer was diagnosed?
From what perspective, Amy, are you thinking?
So I think this is a topic that I know people find very overwhelming. You don't get to stop the service and say, right, let's not take any referrals for 6 months while we redesign everything. You have to just keep working on redesign while there's still patients coming through the front door. What did you learn in terms of how to make that change?
I think for me, it was a close working with Arbaaz. We were lucky to have a project manager that could steer us, and I met with him every week really when we were first developing things, and that meant that we embedded things and we moved on quite quickly if things weren't working and changed things. So for me, that's what made it work, that sort of constant review.
Mm-hmm.
Yeah, I would echo in terms of the clinical leadership side of things as well. That was really important. So Mr. Cross here at Leeds has been absolutely incredible in terms of guiding us and ensuring that the service changes that we are making and planning, are absolutely the right ones. And we were guided pretty much by the data as well. It was a constant review of the data and ensuring what was going on. And the challenge really for us was moving from implementation to embedding, because that sometimes it's very difficult, and we were constant conversations, because a lot of sort of changes had to happen at the administrative level for those stuff to for that to firmly be embedded. So yeah, it was tricky, but ultimately with the leadership from Bill, from Rachel, and the data, we were able to make it happen.
Great. Can I ask, because sometimes in these sort of sessions we hear the rosy good news at the end, and clearly you have lots of rosy good news, but I'm interested, you mentioned spotting the things that don't work. So, revealing the behind the curtain moments for anyone who's on this call and feeling that it's just really hard. Can you share what were some of the things that you tried that just didn't work?
So I'm sort of mirroring what Netty said earlier in her presentation about trying to ignore men with lower urinary tract symptoms. So you can't ignore that. Most men present with them, and it's for them, that's what's important. So we do book people into face-to-face clinics if we need to. Although we're very focused on virtual and speeding things up, we like to make sure that patients had a full assessment. So often we will book them in and review them if needs be. So maybe that was one of our learning points. We still don't see very many men face-to-face, but often those things can be done on the phone as well. So it's a bit of a mixture.
Yeah.
Also, I think getting the template with radiology, so we could give date and time over the phone, massively helped the pathway. I think before that, just booking patients to MRI scan ad hoc and not really being able to give a date and time, and then having to watch out for MRI scans coming in. So that was a really big thing that improved the pathway. It's hard to say now. I think when you get to the end of it, you forget some of the things that are difficult, really. Have you got anything else, Arbaaz, that?
Yeah, I think for me as well is getting the balance right, isn't it, from a workforce point of view? And I think that took some clear sort of modeling in terms of getting your sessions right on a weekly basis to ensure that we are meeting the demand that's coming through the door, because as everybody on the call will know, you plan a certain capacity, but unfortunately peaks and troughs do happen, and then you have to mirror that. So I think that was also a bit of a challenge to make sure that we nail that and have that flexibility to be able to then swap stuff when needed, when we did have those peak numbers as well. I think that, so it was trying to embed change while also trying to run the service. So that was one of the trickier bits, but yeah.
And actually I had a question about that, because I was struck when you talked about flexing your staff and rearranging things in light of the spike of referrals. is that people doing overtime, or are you moving staff from other duties to be able to do it?
So there's only 3 ACPs, 2 qualified and 1 trainee in our team at the moment. And we are flexible on how we work across the week. So if we don't have a lot of men to see face to face, we may put in another telephone clinic, for example. But if we have a surge in men that we do need to assess, we'll put on more face to face clinics across the week. But we manage the whole thing. Very occasionally we may have a registrar working with us, but it's quite rare, to be honest. So no, we don't. It's just us.
It's giving your workforce the flexibility to be able to design their clinics to the needs. Yeah, it's really interesting. Brilliant.
We've got used to it. It was a bit strange at first, saying, "Oh, well, we've got these clinics planned in, but we might change them." Like, oh, right, okay. But you do get used to working in that way, and it's really responsive, and you feel like you're doing a really good job because, you know, by the end of the week, you've seen everybody you need to see.
Absolutely. Yes, it doesn't feel very traditionally NHS to have that kind of level of flex, but it is clearly working because the improvements in terms of the reducing the worry time, I love that phrase, are so marked. So thank you so much for sharing your experiences with us today and for all the work that you've been delivering. And on that, I will take us on to our final presenter for today. So welcome to Jaimin Bhatt. Jaimin is a consultant urological and robotic surgeon at Queen Elizabeth University Hospital in NHS Greater Glasgow and Clyde. So Jaimin, over to you.
Thanks very much, Amy, and the entire team, Joe and Taylor and everyone else for putting this fantastic program together with a very decent number of attendees as well for a Friday afternoon with the sun shining outside, certainly here in Glasgow. And thanks for inviting me to share our work in Glasgow. So I'll just share my screen. Can you see that?
Yeah.
Perfect. Excellent. So I'm very honored and privileged to work at the Queen Elizabeth University Hospital, which is the largest hospital of its kind, possibly in the UK, certainly in Scotland. It is in itself a major cancer center, but also a major trauma center. During the COVID pandemic, it was the COVID hub for all of Scotland and multiple functions with some amazing teams that I have the great pleasure to work with. Again, we have students coming through, both nursing as well as medical students, and a huge learning and teaching organization in itself. One of my proudest hats that I have amongst several hats is being a prostate cancer UK clinical champion. I'm now an alumnus. I was among the second cohort, and it has actually been a life-changing experience. Change is never easy, you know, for anybody and everybody. And I would strongly recommend each and every one of you on this call today, if you've joined a Prostate Cancer UK innovation event, then if you haven't yet signed up for the Clinical Champions program, please do. You'll meet amazing colleagues, not just doctors, indeed nurses, physiotherapists, radiographers, admin people, you know, anyone and everyone who works with prostate cancer patients who are passionate to make better change for their patients. You know, this is an amazing change leadership program. So I definitely recommend this very, very highly. So filters and cascades was something that I'd thought of. I've now a consultant for nearly 11 years, and having worked in a number of centers globally, one thing is, you know, the imbalance between patients coming through the door and the workforce or the capacity, the resource at, you know, the entry point is always a challenge, no matter how well resourced your institution or organization is. And as I sort of went through the journey myself as a prostate cancer surgeon and a diagnostician, it was quite evident that there were places where we could make meaningful and sustainable change. So here's just a model of men who get referred to us with suspected prostate cancer by their GPs with all sorts of different referral reasons, usually following the guidelines, the prostate cancer referral guidelines. Unfortunately, none of these men come with a label that, yes, I have prostate cancer, or no, my PSA is up because of other reasons. And out of these, say these are the men with the highest risk of prostate cancer or bad prostate cancer. How do you filter out those that are likely to have prostate cancer and cascade those who are unlikely to have prostate cancer and cascade those 5 men to the fastest clinics? Was something that I'd kind of been thinking about as we went along. So this was the traditional pathway up until, well, this year actually, whereby a GP referral from the Sky Gateway referral form, which is a standard form in Scotland, would come to the on-call consultant for vetting. The patients would then be vetted to a high PSA clinic, which would be a face-to-face clinic, usually a consultant-led clinic historically. And at that point, we would request the relevant scans, in most instances an MRI scan. The MRI would then get done, it would get reported. The results would come to the clinician's reports file, all online, where they would then action on the result. And if it's obviously a positive MRI scan, then obviously biopsies and other scans and follow-up would be arranged accordingly. Now, if that clinician was off on leave or unwell or on call, that could further delay the pathway. So really a very clunky pathway, which we've seen in our previous speakers' talks as well. So the 5 principles of filters and cascades was, how do we personalize the pathways? We know that not all men who get referred with a high PSA or suspected prostate cancer are equal. How do we make it patient-centric? How do we optimize based on patient factors and not just GP referral categories? On this note, again, admin staff, if they see an urgent cancer suspected referral, obviously the time is ticking on these patients and they need to be seen within the timelines. But sometimes GPs, or if it's a GP trainee, might not have pressed the correct category. And if a patient's been referred as either urgent or routine, that patient may not be seen for much longer. So again, how do we make it an even playing field and not rely on the correct or incorrect referral category? The second principle of filters and cascades was prioritizing. One thing that COVID taught all of us is how to prioritize better. And clearly this was something that helped in some of the filters that I will share with you shortly, such that those who are at risk of having cancer or with the highest risk cancer are seen faster. So that's the cascades. Preservation of resource obviously was something that is very important for all of us, and especially at this time when we are facing huge challenges in the NHS. And how do we save clinic slots and time, and how do we increase our throughput and efficiency? Prevention of missed or delayed diagnosis, or indeed the flip side of over-investigating by filtering out false positives such as UTIs. And lastly, promoting best practice and earlier diagnosis of clinically significant prostate cancer. So these are the 5 main principles of filters and cascades. So the filters and cascades pathway, which we piloted last year over 3 months, basically shifted the whole pathway so that as soon as a GP referral was received, within a day or two, a specialist team, which included nurse specialists and clinicians, made their first telephone call to the patients, inform them that we've received the referral. Normally takes about 1 minute because it wasn't really a consultation, it was a first call. But at that point, request the relevant scans. For most patients, it would be an MRI scan, but it wasn't always just an MRI scan. There would be other scans based on the cascade algorithms. The scans would then get done and reported. And based on the reports of the MRI scans, we had a fantastic administrative person, a prostate cancer pathway coordinator, who would then bring these patients back to the same high PSA clinic within the same time frame, if they were pirates 5, 4, and some selected 3. So at that clinic, they would be seen by a consultant who would then obviously counsel them for biopsies and request the relevant tests. So straight to test, something we've heard in the recent GIRFT document, something that Netty has shared, something that the Leeds team have shared. So clearly this is the way of now and the future of going straight to test and how to make it efficient. And we saw significant reduction in referral from GP to the clinician action of tests. We also saw that there was no further delays on scan results due to leave, as far as, the clinical action goes, because patients were being brought to a clinic. We would counsel patients face-to-face where appropriate in a first face-to-face clinic. And obviously, it also reduced the letters of typing of results going back to patients or GPs when we were able to tell them face-to-face. So these are the 3 cascades, and we've actually split it up so that it's not just PSA, MRI. So PSAs greater than 100 should not get an MRI scan. Indeed, they should go straight for a bone scan, a CT, chest, abdomen, pelvis, and an urgent clinic within the first few weeks to be seen and assessed, and if they're suitable, to start their hormone therapy and arrange biopsies before they go to the MDT. Thankfully, this is not a big number. I know Scotland, compared to the rest of South, has not been doing very well, but this is an area with, again, improved awareness that we are starting to see change happening here as well, that numbers of men coming through with metastatic disease is reducing, but it's still not quite the level that we would like it to be. However, those that do unfortunately present with metastatic disease are clearly being seen faster than ever before and started on their treatments before, faster than before. Cascade 2, where the PSA is between 20 to 100, so long as there is no UTI. If they are under the age of 80 years, we're sending them straight for an MRI scan as well as a bone scan, and then an urgent clinic. If they're over 80 and the PSA is greater than 20 and there's no UTI, they go for a bone scan and come back to a clinic. Cascade 3, which is probably the bulk of our practice, and I think that's where the previous 2 talks have really dwelt on really, is because this is really the bulk of our clinical practice. PSA is less than 20, no UTI, abnormally raised PSA based on previous age-specific levels. Scotland's changing the PSA referral guidelines in keeping with the recent GIRF document that's coming in the near future. So they go straight for an MRI scan and they come for an urgent clinic if they are Pirates 4, 5, and perhaps selected 3. If they are over 80 years, then we go to filter number 2. Now, the filters, if there's any whiff of a UTI, whether it's symptoms or antibiotics or indeed a positive microbiology, then these patients do not go straight to test. Instead, the UTI is treated, we repeat the PSA in 6 weeks. If it's coming down, then they get a virtual clinic in 3 months with a LUTS assessment as required. And if at 12 weeks or 3 months, the PSA is still raised, or if there are any clinical concerns on examination, at that point, further investigations could be triggered. But from our experience, this has indeed saved lots of slots. So we're not discharging patients with UTIs because they do have problems, they need to be seen, and they go to the relevant prostate assessment clinic. Filter 2, which is men who are over 80 years, but PSAs of less than 20 without a UTI. This is a slightly amorphous group, and a case-by-case decision assessment is needed. If someone is 81, 82, and they do have an aggressive prostate cancer, then obviously they need to be assessed and investigated and treated. But equally, it's not taking the same slot. So if we've had 93-year-olds with PSAs of 6 being referred as urgent cancer suspected, all competing for that slot to be seen with other patients. And then the third category, which we are seeing not infrequently, is where the PSA is normal, but a GP DRE is abnormal. And we obviously know that DRE, the indications or the value of DRE is quite usually varied. So we're not again sending these patients for any tests. Instead, if they're under 80, they do come for a face-to-face, slightly delayed appointment, and a DRE is performed by a consultant. And most times, in fact, I would say 9 out of 10, the consultant DRE is benign, and these patients are then reassured, their symptoms are managed, and they're discharged. If they're over 80, then they're assessed virtually for symptoms. So those are the 3 cascades and the 3 filters for our filters and cascades pathway. So we actually piloted our 3-month, audited our 3-month pilot from March to May last year. We had nearly 400 patients who were called and vetted straight to test or filtered as appropriate. A quarter of them, or just under a quarter of them, were referred for biopsies, and on average we had about 30 patients per week. And to compare whether this made a difference or not, we compared this with the historic cohort of the old pathway of nearly 300 patients, exactly the same months a year ago. And the results speak for themselves. So the previous cohort of 2022, referral to first appointment, and we have to remember this includes not just the urgent cancer suspected referrals, it also includes the urgent as well as the routine. The median time was 40 days, which was really, really shocking. Referral to MRI scan was 52 days, and referral to a decision to biopsy was 72 days. After filters and cascades in the pilot, we brought this straight down to 2 days, to 13 days and 27 days. And as you can see graphically there, a huge improvement in the pathway. With the metastatic prostate cancer patients, again, a huge difference, clinically significant difference from referral to first appointment from 28 to 2 days, referral to bone scan, again, within 13 days, referral to treatment, a median of 32 days, which, you know, was a 3-fold reduction, which was, again, very staggering. And another statistic to look at, so in Scotland, we have the 31-day for diagnosis and 62-day for treatment. Just for the metastatic prostate cancer patients before filters and cascades, nearly 84% of patients missed the 62-day target for hormone therapy for their metastatic cancer, whereas after filters and cascades, nearly 88% received, they met the 62-day target of getting their treatment. And indeed, the one patient who missed the target had an equivocal spot on his maxilla, which was then confirmed later on specialized spec CTs and all that to be a MET. So otherwise it would have been 100%. So teams that want to start filters and cascades, what do you need? Clearly, you need the right team comprising CNSs. We've got some amazing CNSs in our team. And as I said in the chat, nurses are really the pillars of every health institution in the world. Urologists, we need support from admin, radiology, trackers, management, GPs, you know, and the bigger number of people you have on your team who buy into your vision, the better it is. The algorithms are here. You're welcome to use them. I'm happy to share these with any team that need to use them. You obviously need to have a start date. And as Amy very aptly put it, that you can't really just, you know, stop the service and then start. You've got to have 2 simultaneous processes hand in hand so that any sort of backlog is dealt with at the same time. And that's something that we're looking to do now that people are coming back from their summer holidays. Obviously, this needs to be job planned and templates need to be built for this to be resilient and for this to continue without any interruptions and not just run on goodwill, you know, because that if members of staff leave or anything else, you know, the system has to be robust enough so that it can continue seamlessly. I cannot underscore the importance of having a prostate pathway coordinator. During the pilot, we were very lucky to have a band 4 administrator who, you know, got the whole pathway and everything was extremely seamless. You know, if patients needed a negative MRI letter or if someone needed to be brought to a clinic straight away, this is a non-clinical person, and this is where some of the other changes, which I'll share with you, were extremely helpful in helping this prostate pathway coordinator to get clinics up and running. And last but most importantly, the belief and not giving up if things don't work out. Again, that's just roles of who needs to do what. So vetting is done by the consultant team straight to a next day appointment or within the next couple of days if it's a weekend. And that's where the admin support is absolutely crucial. They're booked to a virtual clinic, and this is where the CNSs and clinicians will book the relevant scans based on their different cascades. Now, if someone has a negative MRI scan, then the prostate pathway coordinator will pick up on that MRI report if it's a PIRADS 1 or 2, and a standard negative MRI letter with some advice on how to manage their urinary symptoms is sent both to the GP and the patient, including starting them on symptomatic men on tamsulosin, for example. We do not discharge these men. They get a 6-month virtual appointment for a repeat PSA just in case, you know, their PSA is still raised. We also use PSA density to guide whether they need future biopsies or not. And obviously the filters, again, are similar as we discussed. And again, the admin staff are crucial in booking the relevant bookings, clinics. The trackers are also very helpful in making sure that people don't slip through the net. And then obviously the clinical teams make sure that the relevant tests are done. So what are some of the other positives that have come out of this? We have actually made changes to the gateway referral so that we can try and build in the filters from GP land so that if someone's got a UTI, they should not be referred for prostate cancer assessment. They should be treated first, and then after that, if there are still concerns, they can be referred. And this has led to closer working with GPs, including the GP cancer leads. One amazing thing that's emerged out of this is also our fantastic radiology colleagues have come up with a standardized performer for MRI reporting so that the likes of our prostate coordinator or our cancer trackers can look at this and say, okay, this is PIRADS 1 and 2. They do not need to come to a clinic. They get the standard negative letter. They obviously run it past the clinical teams before the letters are sent out, just again from a governance perspective. And it's how do we automate systems so that they run pretty much seamlessly and with minimal sort of effort or input. As you can see, there's quite a lot of information in the proforma, as I've indicated there, which also helps in, making further treatment decisions as well. We're also finding that fewer patients are getting bounced back from MDT. For example, if the MRI provisional staging is a T3A, if the PSA is, say, 9, that person would still need a bone scan as per the guidelines. So that would be requested before they go to the MDT while they're getting their biopsies. As I said, the negative MRI scan letters during the pilot, we were saving 10 new clinic slots a week, and we've had excellent patient feedback as well. So ripples of change have started. The Scottish Cancer Network, I lead on the diagnostic subgroup for clinical management pathways. When I shared this data with them and the algorithms, there was unanimous uptake across all the different regions in Scotland, and with a move to actually rolling out the filters and cascades pathway across Scotland. We've also revised the new Scottish Cancer Referral Guidelines for prostate cancer, other than the values, which will come into sort of into space and practice once they're confirmed. One important thing is that the UTI aspect has been really highlighted, and that even if the PSA is coming down at 6 weeks, hold fire, do not refer, check again after another 6 weeks, and if it's normalized, do not refer. So that has been really helpful as a result of this project. We've had a very meaningful meeting with the Northern Ireland Roundtable Group just last month, and again, I think there's interest in trying to roll this out across across there, as well as several centres in England through the Clinical Champions Project have approached me for sharing the algorithms. But one important thing, and again, seeing Arbaaz's and Netty's talk and Rachel's talk, is how do we share best practice? How do we network with our innovation teams? We've got amazing colleagues in my department who are always looking to see how we can make change and improve our services. How can we network locally, regionally, nationally, and globally as well? So a huge thanks. Obviously, this can not happen without all the various people in my team. I can see a few of my CNSs are on the event today. So a big shout out to each and every one of you, Fiona and colleagues. And yeah, change, as I said, is not easy, but if we always do what we always did, then we'll always get what we always got. So let's start the ripple of change. Thank you very much.
Thank you so much, Jaimin. Really great presentation. There's been some great action going on in the chat. If anyone else has any questions, please drop them in. And I can see that Taylor's just dropped a link to the Clinical Champions Programme, which Jaimin so excellently plugged for us. So thank you very much for that, Jaimin. I have a first question for you. I've known about your work for quite some time. I had the pleasure of working with you as a clinical champion, and I was describing it to a stakeholder whose reaction was very negative, and they said, "Isn't this just about rationing care?" And so I guess my question to you is, how would you respond to accusations that filters and cascades is about rationing access to care?
Well, I guess one of the ways that one can answer to any critics or cynics, as we've done in Glasgow, is show the data. The data speaks for itself. It is definitely not about rationing care. It is about making this whole pathway patient-centric and prioritizing based on, so none of the patients have, if anything, numbers of MRI scans have not gone down. Neither have they increased enough to cause, our radiology colleagues to lose their sleep. So it is actually about being smart, being efficient, being smart enough that, if there are only 10 slots, unless we create more capacity, which we know is impossible, unless we, suddenly just click fingers and doctors and nurses drop out of the sky and clinics and hospitals start just emerging from the ground, that's a utopian belief. But, how do we make the most of the situation and you know, be smart and resourceful. So it's certainly not rationing care. And as I said, you know, if you've got the data, share it. And I think that in itself speaks for itself. So the power of the data is huge.
Absolutely. And I particularly am struck by how much faster men with metastatic disease are being treated. I think that's incredibly impactful story to tell.
Indeed.
What do you think? Do you think there was some specific circumstances to how you operate in Glasgow that enabled filters and cascades? Or do you think that this is something that actually is highly transportable to other areas?
So it is, yeah, I mean, obviously, as I say, change anywhere is difficult. But if the change is done in a way that, you know, the power of simple, as we discussed before, is huge. You know, if we bring in a very elaborate system that's difficult to sort of introduce and run and navigate, then that obviously any complex system has a higher risk of, you know, uptake or breakdown. But if something is simple enough, and as we've shown, the algorithms and the filters and the cascades are simple enough for, and we have shown that actually this need not be run by consultants or, you know, anyone and everyone who has a belief and passion in wanting that change can. So it is very, very generalizable. We have had other centers adopt this as well. Now, clearly, there will be some teething problems. We've had our teething problems again because of lack of the prostate coordinator currently, and we're obviously seeing how best to address that, and, you know, how do we make sure that the roles are filled correctly by the relevant admin staff and who's doing what. I think having that clarity is absolutely key. But I think the answer is yes. I think it is very generalizable, and then once we've got the principles, right, and the filters and cascades, I guess any department can then adapt and modify and make it work for them to their best available resource.
Yeah. Thank you very much, Jaimin. I'm going to do a little bit of a wrap up. I am very aware that we lost Netty unexpectedly midway through her questions. If anyone was desperate to ask Netty a question, I've seen she's been very active on the chat. Thank you, Netty. But she is now with us again. If anyone had a question they were very keen to ask Netty, we can pick it up now. But just in terms of a wrap up, I think firstly, I would like to say a massive thank you to all of our speakers today. We really wanted to show you a breadth of ways that the challenges around the diagnostic pathway are being addressed, because our experience is that there isn't a single model that is the perfect model for diagnosing men faster within a very complex NHS. And actually, what we see across the UK is that lots of people have identified ways to make this work, but at the same time, there's lots of people who are still really struggling in this space. So we wanted to show you a few different solutions so that you can see which one feels like the one that's most achievable, the most aspirational for your particular trust. But I think listening to our speakers today, there are some real common themes across these around having that real clarity of roles and responsibilities, having absolute clarity around who's responsible for the patient at each point in the journey, actually knowing who's in your system and having that data clarity. That was a real theme from all the talks, and you know, whether that's the fabulous dashboard that Leeds showed us, or the Excel spreadsheets, the data that Jaimin was able to share showing the difference. I think that's a really important theme. How are you tracking who's coming into your system and what the results are for those individuals? And I think that takes us on to the final theme that really struck me, which was around being really patient-centered in this and understanding that actually one size doesn't necessarily fit all when it comes to a 2-week wait referral for prostate cancer. And it's really important to understand who the patients are, who are being referred, what their wider context is, and therefore what is the right referral route for them. But let's wrap up this topic here. just a couple of quick notices. So we have a conference running in September for anyone who is interested in how the evidence base around the role of the PSA test in asymptomatic men is shifting. And we published this week a new consensus on the use of the PSA test in the British Journal of General Practice. And we are delivering a conference in September where we've got some fabulous invited speakers who are going to talk you through that evidence base around how the harms and benefits within the diagnostic pathway have shifted and what that means for the information that we're giving to patients. So we will drop a link to that into the chat. Finally, I mentioned earlier that we always share an evaluation after these events. We do really appreciate you taking just a couple of minutes to complete the evaluation. We run these events roughly every couple of months. It enables us to make sure that the topics are interesting to you, that we get the right speakers in, that we get the right kind of content that actually supports you to deliver improvement for men with prostate cancer. So please do take a couple of minutes to fill in the evaluation form. We will be in touch with everyone who registered in the next couple of weeks via email, where we will share a recording of today's presentation. So if you sat here and thought, oh, I wish my colleague could have seen this, you are very welcome to share the recording with colleagues, with others. And we will circulate slides from the presenters as well, because I know some of the slides were quite detailed and quite hard to always see all of that as somebody's flicking through a Teams presentation. But that is it. So thank you all of you for giving up your time on a Friday lunchtime. Thank you to all of my team who helped to organise today, and to our brilliant speakers. And I wish you all a lovely Friday afternoon.